Good morning, everybody. Let me first welcome and introduce this next panel, and I'll start down with Laurel Pickering on the end. She's the president and CEO of Northeast Business Group on Health. Welcome. In the middle here, we have Barry Ostrowsky, head of Barnabas Health, which, as many of you know, is the largest hospital network here in New Jersey. And then right next to me, Ray Castro, who is now a senior policy analyst at New Jersey Policy Perspectives. And before then, you spent about 3 decades working in the New Jersey state government.
Right,
So
yes.
you're coming at this from a couple of different perspectives. As you may gather from the panel, who we've got up on stage here, we're going to drill down in this next session on the situation specifically in New Jersey. And on that front, you will not be shocked to hear that there is good news and bad news. On the good news front, New Jersey consistently ranks in the top third of states for overall health of its residents. Also, the number of New Jerseyans with insurance is up. That's according to the latest census data, showing that the share of New Jerseyans without health insurance dropped 17% last year. That's the good news. On the bad news side, New Jerseyans, like Americans everywhere, still face a maze of obstacles when they're trying to navigate their way toward affordable, quality health care. And people here face pay the second highest health care premiums in the country. So, Barry, let me turn to you first and ask.
Let's make it about the good news.
Is it the best of times? Is it the worst of times?
I think it's the best of times. That's not because we're not challenged by all the bad news that you shared with us. I think we have at our disposal the tools. I think we have the resources. And I hope we have the will and courage to, in fact, correct the weaknesses in the healthcare delivery and financing arena that we face in New Jersey. I think medical technology, I think most importantly, the clinical quality of those who provide the care has never been better. I think we're stuck in a very old structure when it comes to financing, when it comes to the venues for the delivery of care. And so I think we need to break free of an industry that has gotten very comfortable delivering the product in one fashion, and we have to move that into a very different structure so that we can enhance the good news. And by the way, from our standpoint, some of that good news is really an average. The demographics of New Jersey suggest that while there are people who have access and who have quality care at a moment's notice, there are people in this state who don't have that access and are living lives that are challenged because they don't have the access. And so I think some of the good news, as much as I hate to say this, some of the good news is skewed because it is an average. I think there are really big needs that have to be addressed.
But this figure that New Jersey's healthcare costs per person, second highest in the country, why?
Am I still up? Okay. Well, I think we heard it earlier this morning. I think one of the structures to which we have been wed for very long is this fee for service, fee for quantity, fee for volume. And that in and of itself is an organic approach to financing that can't do anything but increase the price. I think of myself as a believer in capitalism, for sure, but I can tell you that when you impose that kind of financing structure on care, you're going to get high cost. I think there are alternatives. We don't have sufficient outcome data. We may not have sufficient value definition, but we have to move towards paying for that which is valuable to the consumer. And there have been courageous steps recently taken to try to do that. But I think our price and cost is skewed by this financing structure, which is going to have to be transformed into a much more effective approach.
And I want to follow up with you in this session on some of the steps that Barnabas, I know, is trying to take on that front. But Laurel, let me get you in here. You, as the title of your organization suggests, you deal with a number of states, Northeast Business Group. Weigh in on this question of specifically what's happening in New Jersey that is making costs so high compared to the rest of the country.
I would echo what Barry said. I think a lot of it has to do with the payment system. I think you see other parts of the country.
Is that unique to New Jersey, though? That's the way.
Well, what I was about to say
is
I think you see other parts of the country that are accelerating the move to value-based care and value-based payment. And when I look at the states that we work with our New York, Connecticut, Boston, New Jersey, New Jersey is behind some of the other states in really moving toward value-based care and value-based payments. So I think that's a lot of it. And the business community is really struggling with the cost issue, clearly in New Jersey, but all over the country as they're faced with the Cadillac tax looming. And they've have to reduce the cost of their benefit plans while we still have these very high cost systems.
The Cadillac tax, just to explain, as something that the businesses that you work with are grappling with, trying to figure out how to deal with the employee health care benefits that they're providing.
Right, because in 2018, they're going to be taxed if their benefit costs go above a certain level. So they're all struggling to bring those costs down at the same time that they're struggling with a delivery system that's very costly.
Ray, do you see other factors at work here in terms of what's shaping the landscape specifically in New Jersey?
Well, I think part of the problem is that this is an historical issue. I mean, we've been high cost for the last couple of decades, so our base is high. And so that's what we have to work with. And I agree with the comments made that, you know, I mean, this year in particular, I'm starting to see some progress in terms of trying to bring those costs down. I think we're always going to be on the high side, right? Because, I mean, we are in the Northeast, we're right next to New York. But certainly we can bring it down to this, you know, we don't have to be the highest in the country.
Okay. Yeah. Okay. Wait, I mean, I guess the obvious follow-up question, costs here are very high. New Jersey folks pay more than in other parts of the country for their health care. Do they get better health care in return?
Well, I think better is, for me, better is a difficult definition. I happen to be of the belief that clinical care that's received in New Jersey is second to none. So, you know, people in New Jersey say, well, do I have to go to New York? Do I have to go to Philadelphia? Do I have to go to Rochester, Minnesota? I think the clinical care in New Jersey is excellent. We have outstanding physicians, which really drive health care in terms of quality. I think we have good institutions. Now, do we render that care in a way to try to be efficient while we maintain quality? Do we render it in a way where we enhance the patient experience and where we get the best outcomes? I don't know that we do. I think there's a lot of improvement in those areas. But I don't think we are overcharging for a poor product. I think the product is very good in its intrinsic value, but I think right now the cost structure around it needs to be fixed.
Well, let me press you on that. I mean, you mentioned that it's your view that this fee-for-service model is antiquated. What are your hospitals doing to move away from that?
Well, we have participated in basically every pilot project that we can that was launched by the government programs. We, of course, are a partner in the new Omnia product, which courageously has been launched by Blue Cross. We are getting our delivery system to understand that the future is about a more efficient, value-based charge structure or payment structure. Now, look.
What does that mean? Is it the hospital should make money based on the wellness of the patient?
Absolutely. I'd like to see our revenue stream develop so that we're incentivized to avert illness. We haven't talked about that. Look, when it comes to people who are sick, there's a better way to treat them more efficiently and maintain quality, and that's to first understand what the patient needs and make sure that you organize all the reaction necessary to the needs of that patient. So you're not hopscotching around looking for clinicians, that there's some integrated way to say, this patient needs this outcome, which can best be gotten through a coordinated effort among institutions and physicians and other clinicians. That's not been our culture, has been said. And so developing that team approach and developing that reaction to people in need is going to take perhaps years to accomplish. We have to match it up with a financing structure that says that's what we're going to pay for. And that's how we're moving at this point. Our organization is committed to trying to invest its resources in averting illness. I mean, how do we get people not to get sick? And in our view, there's a percentage of people that are accessing the healthcare system now that wouldn't have to access the healthcare system if the lifestyles they led were improved. And then the resources saved would be more than enough to take care of anyone who effectively gets sick. People are going to get sick. We're never going to be 100% successful in that pursuit. But I think that's our new business plan, and it has to be. And that's
Laurel, let me let you jump in here and give us the business perspective on this, because I know your organization's been involved in some of these efforts to try to keep people out of the hospital, to
Yeah, I mean,
move to a wellness.
I was gonna just jump on that. We are waiting for health systems like Barnabas to do this. When you think about the companies that we represent, they're mostly national, global, self-insured companies. Like right here in Newark, we have Prudential, PSE&G, Princeton University, Curtiss-Wright, many in New Jersey, and they have hired multiple vendors to fill the gaps in the healthcare system that are not happening for their employees. We have one of our companies said, I have 23 vendors that I've hired to fill those gaps. I obviously have a health plan. I have a care management organization. I have a telehealth company. I have a transparency vendor. I have a 24-hour nurse line. And I could, go on, because the healthcare system has not been incentivized to keep people well and keep people healthy. So we're waiting for systems like Barnabas to get ready to do this in partnership with their health plans. So we absolutely support the move toward value-based care. We'd love to eliminate some of those vendors that we're paying for and let the healthcare delivery system provide the
Ray, she
outcomes.
says business leaders are waiting for it. The hospitals want to do it. What are the obstacles?
Well, I think also the consumers are waiting for it. I mean, I think my concern is that a lot of these quality indicators that we discussed is sort of inside baseball. I don't think the consumers get it at all. Part of the problem is that there's no agreement on what quality is. And also, a lot of the most important indicators are not even available to the public. So if you go on healthcare.gov and you look for a plan, it's all dollar and cents. This is what the premium is. This is what the cost sharing is. So Omnia looks pretty much like all the other plans. The really innovative aspects of Omnia are not on the website in terms of the large network, in terms of the patient management. All of that is not there. You really have to dig to find out how many providers there are. I have to click the directory and count them for each insurer. So it's just not doable. So some of the things that are most important to us, that we're not translating that to the consumer.
Please, yeah.
Just to follow up on this, I hope for the day when I can go to a business and say, you now spend $100 million on health care benefits. We've analyzed the population of your employees, and if they lived a healthier lifestyle, that $100 million would be $80 million. So I want to sell you a guaranteed product, so you're only going to have to spend $80 million. Now, the issue is, to Ray's point, I need consumer buy-in. If I'm going to sit down with the employees and say, we're going to help you avert an illness or a condition, but you're going to have to do this, if we don't educate our colleagues, our consumers, our friends, that that's a necessary commitment, frankly, all of this is just an academic exercise, because you can cut price here and be a little more efficient. But if there isn't buy-in by the consumer, we're never going to get to the stage where it's most affordable, most productive, and I think would reinforce a great public policy. I don't know that any of us yet have figured out how to engage the consumer in that way.
But I think businesses are working really hard to do that. I think businesses, seeing that they've had to lower their healthcare costs, are very intent on engaging employees as better healthcare consumers, and they're making requirements of them. Like, we pay for your healthcare benefits, and in return, you're going to do a few things to basically earn that privilege. And so we see more and more companies that are not as many maybe in this area, but I think it's going to come, that are saying, if you want this procedure, you're going to have to go to this place for it, because they have better outcomes, there's better value, and you're going to have a better result. We see them asking them to do wellness activities. There's more and more requirements that employers are putting on employees to make them better consumers and really earn the benefit dollars that the employers are paying for.
I mean, this all raises the question of public-private partnerships, what role government plays in all of this. Ray, whether it's looking at the local level here in Newark or the state level, what opportunities do you see for the government to be working more hand in hand?
Well, to me, one of the greatest challenges we have is, in my view, the healthcare industry is light years ahead of the public the legislature, and even the state government in terms of innovative changes. You know, we have a lot of very dynamic leaders here. We have these changes that are occurring at a dizzying pace.
Like what?
Well, in terms of hospital consolidations, new plans, you know, the way that services are being designed, you know, in the last couple of years, we've just seen amazing changes. And the press, I mean, and the public reads about this, but they don't understand what it means to them. So I just think that there's a very big disconnect. I would like to see much more role in terms of the state, because, I mean, one of my biggest concerns is outcomes. But by outcomes, I mean statewide outcomes, not, because I think, you know, in our discussions here, it's a lot, what is the provider community doing? But I think as a state, we have to be looking at what the bottom line is. And we also have to broaden some of the social issues, which are important, like poverty, for example. And I know that the healthcare industry traditionally does not get involved in those roles, but poverty is a huge issue in our state. We're seeing it increase every year, unlike many other states, and our economy is not doing that well, and poverty is going to continue to be a big issue. And I know my organization is going to be issuing some recommendations on changes in policy in that respect. We would love to get some of the support from the healthcare industry, which you traditionally do not do, but I think you have to sort of you have to broaden that perspective. But I would like to see the state to be more involved in terms of dealing with the transparency issues and the accountability issues. I'm getting the feeling that there's sort of no one at the top looking at all these changes and trying to put it together.
Mm-hmm.
Yeah, I mean, to make a comment particularly about New Jersey, you know, we, and I know this is probably politically motivated to some extent, but we're seeing in New York a ton of money pouring in from CMS and the Innovation Center and the federal government to reform healthcare in New York. We have a huge Medicaid reform initiative. $6 billion came from CMS. We have an advanced primary care initiative transforming primary care, $100 million from CMS. And we don't see the same level of money pouring into New Jersey in that respect. So clearly the private sector is reforming on their own, and it would be good to see New Jersey stepping up to avail themselves of those kinds of resources that we see in other states taking advantage
So something
of.
specific you would like to call Chris Christie and tell him you need to get on this?
I don't think he'd take my call, but
Well, just in case he doesn't, I think it's going to be left to the healthcare industry to really forge that type of process. I think that as a state, I mean, we as a state, we have no mission for healthcare. I mean, it doesn't really exist, and we certainly don't have a consensus on that. And I think, you know, my perspective is that a lot of providers talk with each other. And this is really the first year where I saw a lot of communication with consumer groups, and particularly on the out-of-network bill. And I found that very, very encouraging. I mean, for the first time, we were sitting down with insurance companies discussing some of these issues like surprise billing and so on. And we have to build on that, I think, because, you know, I think as the hearings on Omnia showed in the Senate, there's a big gap there in terms of where the legislature is and the public and all the changes that are going on. And I think it's going to be very important though, to educate the community so that we avoid a lot of that miscommunication.
You mentioned the Omnia hearings in the state Senate, and the Omnia question has come up a few times in this conversation. This is, you know, an effort to lower costs for consumers.
Absolutely.
From Horizon Blue Cross Blue Shield. It has proven controversial, to put it mildly, here in New Jersey this fall. Horizon says that it would lower costs for consumers, both out-of-pocket and premium, that it will reward hospitals and doctors for efficiency. Why are New Jersey lawmakers not dancing in the streets? Yeah.
Well, there are a couple of reasons. I mean, first of all, they were surprised, right? They didn't know anything about this. And when it was announced, understandably, Horizon emphasized what a very important change this was going to be in the delivery of health care and all the people that were going to be affected. But if you're a legislator, you're wondering, well, so why wasn't I involved in that? You know, I mean, they're supposed to be setting a lot of the policy for the state. So I think it was so that and then of course all of this had to be on the marketplace within a month. So so I think they were very frustrated by that. And I think there was a lot of initial planning, and I realized there were a lot of barriers to this because I know we have a federal marketplace, and there are certain limits in terms of the information that you can provide.
Well, let me flip this out. Do we have Horizon in the audience with us now? I wonder if Bob Marino, are you back here?
Yeah.
Oh, let's give Bob.
Back here? Not in the audience right now. Let me flip this to you.
here.
Yeah.
Yes, we do. Right here.
Right here.
Sorry. Can we bring the mic over to you? I wonder if you want to take this question about why not more transparency, why not have lawmakers able to weigh in with more oversight, why not select the partner hospitals in a more transparent way?
Well, the process that we used to develop the Omnia network was a very deliberative internal process. We found it to be rigorous. We thought it was objective. 75% of the criteria that was used to evaluate the Omnia network were objective metrics. Over 50% of them were publicly available. And candidly, the process that we use has been used by our competitors throughout the state. It's not atypical for a carrier to develop a network in the manner that we did, and we just chose to use that process. We thought it was best for what it was we were trying to achieve.
And can you shed some light on why you had to exclude some hospitals? Why develop this Tier 1, Tier 2?
Well, we had very rigorous criteria. There were 6 criteria that we used to evaluate every hospital in the state. Quality was clearly part of it, but there were 5 other criteria as well. Obviously, the partners that we chose, we believe, were intellectually aligned with our vision to move the system towards more of a value-based system. They clearly had demonstrated that commitment, and we felt strongly that they would be aligned with us as we embarked on this transformation of the system. And clearly, as you know, our ability to offer a lower price in the marketplace is a function of negotiation, and it's a trade-off of volume for price. I think that's a fundamental of managed care, and I think that's one of the fundamentals that we used in developing the Omnia network.
Okay. Just one more question that I'd love to give you the chance to respond to, and then Barry, I don't know if you want to weigh in on this as well. I know Barnabas is one of the networks that's going to be involved in this healthcare plan. One of the other concerns that's been raised is that this plan may put some hospitals out of business, may leave some communities with no hospital whatsoever. What are you doing to make sure that that won't happen?
Well, we don't necessarily share that view, quite honestly. As I indicated earlier in the day, that our initial enrollment for year 1 is 250,000 members out of a base of 3.9 million. The product's not available in the Medicaid or the Medicare market at this point in time. I think there's a long path between us introducing an Omnia product and us causing hospitals to close. We just don't share that view. We have met with many of the Tier 2 hospitals. We've presented data to them to actually show the financial impact. We actually think it's a little bit overstated, quite honestly.
I have read that you're trying to think if there's another thing to call the hospitals other than Tier 1, Tier 2.
Yeah, obviously. I mean, this was a very large...
Not a value judgment.
Yeah, no, this was a very large-scale initiative, and it's new. And obviously, whether it's a public sector or private sector initiative of this scale, there's always an opportunity to reflect on what you could have done differently. Clearly, one of the things was the nomenclature we used, Tier 1, Tier 2. That's industry nomenclature. It's actually used by the federal government. But unfortunately, some concluded that the connotation of Tier 2 suggested less quality. That was never our intent. This was never a statement about quality. All of the hospitals in our network are quality institutions. So we are looking at that. Maybe we need to change the nomenclature to something that doesn't connote what some perceive it to connote, and we're in the process of doing that.
Thank you. Thank you for fielding the questions. Laurel and then Barry.
I just think it's important to point out that not every health system is on a value-based care path. And I know that Horizon worked particularly with health systems that are intellectually there. They're headed in that direction. But not every health system is. I mean, there are some health systems I know that clearly feel that the fee-for-service system benefits them. They make a lot of money on it. They're not changing the way they deliver care or the way care is paid for. So we have to remember that there are some that are digging in their heels and saying, we're not going to change because this system, the way it is, benefits us. And I think they're going to be left behind, because the systems that are forward-thinking are going to be the systems that employers are going to want to work with, health plans are going to want to work with. And I think that's what you're seeing playing out here, is that some systems are ready, they're moving ahead with the rest of the world where we're headed with value-based care, but some are not.
Gary, what about this concern that this and other trends in the industry are going to end up with consolidation, fewer hospitals, fewer insurance groups, some CEOs controlling everything, and the costs are going to be jacked up for the average Joe?
Bob, how about good, better, best? Is that okay? Better than two? I really think that's a very big issue, but I would answer it this way. The Omnia product is not going to close any hospitals, and I say that from inside the industry, and I'm sure my review is consistent with that of Horizon Blue Cross. We've had a lot of hospitals in New Jersey, and we still don't, in my view, have the health outcomes that we want. Newark is a perfect example. 300,000 people in Newark need better health care. We have 3 hospitals. So there will come a time, I think, when we'll sit down and say, what do the people need? Do they need more hospitals? Or do they need more physicians? Or do they need more clinics? How are we going to get to the real issue, which is how are we going to raise the health status of the citizens of New Jersey? And so I know it's controversial and provocative to talk about the closure of hospitals. Our system has closed 3 hospitals over the course of 18 or 19 years. And after closing those hospitals, I received not one letter from a consumer, from an elected politician, from a thought leader of the community complaining that that facility was closed. And that's because the need of that community was not for a hospital. The need for that community was something other than a hospital as a healthcare destination. So I think we frequently get caught up, and I'm not suggesting by any means that we won't need hospitals, but we'll need certain kind of healthcare delivery venues, which may not be hospitals. And so to some extent, New Jersey is going to have fewer hospitals, and I might predict that fewer hospitals at some point will actually raise the level of health care in New Jersey because the resources will be distributed to better approaches to delivering care.
We're going to open it to questions in just 1 minute, but Ray, let me just let you respond. Do you buy this, that fewer hospitals does not necessarily mean a reduction in great health care for the citizens of New Jersey?
It doesn't necessarily, but it does raise a question, who is watching this? And I thought that was pretty clear at the Omnia hearings that the state is not, and that we have 3 state departments who are involved in this process. The Department of Human Services in terms of Medicaid, Department of Health in terms of hospitals, and DOBI in terms of insurance. I don't get the impression that all 3 of them are working together on a lot of the issues that were raised at this hearing. And in fact, it became very clear when the legislatures asked the state, they're limited in terms of the information that they can even collect. They have these very specific standards. As long as you meet that one standard, then you're fine. But it doesn't really have to do with access in a particular community. So I feel that we need much more state involvement. We need a lot more requirements in terms of transparency. And I think the healthcare industry has to be a part of that. Because this could be done in a negative or a positive way. We don't want so much oversight that it stifles the incredible innovation that's going on in our state. At the same time, I think it's the benefit of all of us that the public understand what's going on and that they be part of this very exciting process that is going on in our state.
All right, well, let's open it up to the public. If you've got questions, raise your hand. We'll get a mic to you. This lady right here, give us your name.
Hi, my name's Catherine. I'm a graduate student, and I was a community organizer in the South Bronx for several years. And my question is, a lot of times we talk about the costs, and it gets directed straight to the insurance companies and the hospitals. Why are the costs not going down? And I want to know what your perspective is. Why hasn't there been more pressure on drug companies and malpractice insurance to lower their costs? Because we have a CEO of a drug company recently raising the price of a generic AIDS drug to like $730 a pill. And under the free market system, that's considered to be just fine. But then people want to know why the hospitals are so expensive. And it's like the hospitals can't just not charge anything when they have costs.
Laurel, do you want to tackle this one? Why such high costs being passed on from drug companies?
Yeah, I guess that it's, I think from the business community, it's not something that the businesses have, been able to or are interested in taking on. The businesses that I work with all are, trying to invent innovative products that sell at the best price, so they wouldn't probably put down an industry in that respect. But what my members do, though, is they put in various programs and controls and levers to facilitate the best use of pharmaceuticals, the best value pharmaceuticals, and use those levers where they can. I mean, they want their employees to have access to medicines. They improve health. In some cases, employers want to spend more money on pharmaceuticals and less on hospitalizations and medical care because that gets a better outcome at a better price. So I think it's more about using levers, looking at best value, at least from the business community. And I think we're not interested in taking on the pharmaceutical industry because there is tremendous value that they provide. So you're probably not going to see that from our sector and from us, but I don't know if we'll continue to use the levers we have.
You're raising a really important point. In fact, Kaiser just came out with a national survey on what were the biggest concerns of the public. Prescription drugs was number one, dwarfed all the issues that we're talking about. And there is some legislation that is pending that deals with the cost sharing in prescription drugs. And I know the New Jersey Healthcare Coalition, of which I'm a part, this is a very big issue. So I expect some reforms in this area.
Very big, very tough one. This gentleman right here.
Hi, Fred Mogul from WNYC New York, New Jersey Public Radio. And I wonder, Barry, if you could talk, you had mentioned, as an example, hypothetical, if you went to a business and said, you spend $100 million, we can get you down to $80 million with more programs. I'm guessing one or both of the prior panelists would kind of express a little skepticism about that and about transferring the cost to the patients. And I just wonder what sort of, I think they would probably point to the costs of salaries and surgeons and executives and billboards and other things. What role really do you have in terms of controlling costs? Do you not think they're at all inflated?
Oh, I think costs can come down and should come down. But my point about that hypothetical wasn't about price reduction. It wasn't about cost shifting. It's not a savings if the business pays 80 and the employees pay 20. We haven't reduced costs at all. My point is that healthcare organizations like ours have the intellectual capacity and the clinical skill and the social skill to help people live healthier lifestyles. And so if you're spending $100 million because the demand for clinical services is at some level, we should be able to bring down that demand to a much lower level if the consumer, and I understand there's a growing commitment to wellness, but it's not anywhere near the kind of wellness suggestions and commitment that we have on the clinical side. So if we get as serious about wellness and better lifestyle to reduce healthcare costs as we are in the innovation of new technique and new medical devices, we will bring that $100 million down without cost shifting. And certainly the extent to which we're inefficient as a delivery system, whether it's my salary or the number of technologists we have in a given department, that needs to be made more efficient. But I don't think that's the big difference, candidly. I think it's a consumption issue, and some of that consumption is unnecessary. We just haven't done anything to withdraw the unnecessary consumption of healthcare services from the public. And that should be, to me, a much bigger focus than it's been.
We've got one more panel to get to, but let me just wrap it up with one question and get just a quick rapid-fire response from all of you. This riddle of costs versus care, which is at the heart of everything we're talking about this morning. It is. I mean, if we walk away from anything from this session, it's that it's controversial. It is complicated. Is the bottom line that it's going to be painful? There are trade-offs that are going to have to be absorbed from every front. Yeah, Laurel.
Yeah. There are going to be trade-offs. There are going to be winners and losers, unfortunately, because everybody is making money at this. And one thing that we didn't talk very much about that I think is really going to help with this is consumers and engaging consumers. And from the employer perspective, that's something that we're heavily focused on. So I think engaging consumers in this process is going to help us in this journey.
So the role of the consumer, Barry?
I think it's a cultural issue. I think we're used to having a healthcare delivery system with the attributes that have been described all morning. And if you're going to make that system better by changing those attributes, it's going to be a difficult cultural transition. I say to our people, I'm old enough to remember when we used to have public service announcements about not throwing garbage on the ground. Don't be a litter bug. So if we had to teach each other not to throw garbage on the ground, what's it going to take to teach each other to eat broccoli instead of beef jerky, you know? So it's a cultural issue, and I don't think we can ignore that. We can dance around the edges on data analysis, but if we don't get to the heart of the way we live, we're going to have this, discussion for the years to come.
Ray, quick last word.
so-
Give us hope.
Okay, yes, public education. Because I think that, the public, most consumers, they only look at the cost to them. They don't get the bigger system. And that was a problem with our out-of-network bill. They didn't get that, because they're protected from a lot of this higher billing. They didn't understand that all that goes to the insurer, and then the insurer has higher premiums for everyone. That's kind of a complicated issue, but it's critical that we educate consumers that it's not only about their individual costs. They have an investment in the entire healthcare system, just like the rest of us to be there.
All right. Clearly, we need to reconvene in a week and panel on educating consumers. For now, thank you all so much. Ray, Barry, Laurel.
Thank you.
Thank you.